Great. There's so many more and more people that continue to join. This is awesome. Good way to start our week.
Ellie, my first couple of slides are really intro, so if you want to get started.
Okay. Yeah. All right. Well, I want to thank everyone who is joining us today and still joining for this Learning Network webinar on threats to Medicaid and the health of women, birthing people, and children. This webinar will be presented by Kay Johnson, who I'd like to take a moment to introduce. Over the past 40 years, Kay Johnson has become nationally recognized for her work in maternal and child health policy as a researcher, advocate, and consultant. Reducing the impact of poverty and racism and increasing access to services for women, children, and their families have been two of her lifelong goals. Her work at the Children's Defense Fund, March of Dimes, George Washington University, Dartmouth College, and Johnson Consulting have shaped the direction of MCH and Medicaid policy since 1984. She has been active in Medicaid and other health policy at the federal and state levels and an advisor to more than 45 states. Her expertise and publications encompass a wide range of women's, children's, and family health issues. She is a longtime friend of CityMatch. Prior to her policy work, Kay worked for 7 years providing direct services to low-income families in child care centers. I'd like to let you all know that we are recording this webinar, which will be posted to our CityMatch YouTube page following the event. And if you have questions, feel free to add them to the chat or take moments when offered to ask questions out loud. I am going to put an evaluation link in the chat here quick. If y'all can just click that and have it open for when we are done. But I thank you for joining once more, and I will pass it over to Kay.
Thanks, Callie. I'm so delighted to be here today. I'm really happy that many of you are interested in listening and learning and talking about this. I am really working full-time on the threats to Medicaid, what I would call Medicaid defense in 2025. And I want to tell you a little bit about why I'm doing that. I'm going to turn off my camera so you can focus on the content. I'll turn it back on when we're doing discussion. But I really appreciate you being here and am glad to talk to you about this. So I'd just like to begin by maybe augmenting my bio a little bit, which is to say this picture shows two generations of grandparents. It shows 3 of my siblings. Here's a picture on the lower right of my mother and my father and their firstborn baby, my sister Margie, who's 88 years old now. And that's me, that's baby Kay there in the middle. As you can see, a lot of challenges, a lot of poverty, a lot of opportunities, a lot of social drivers that affected my family's life, my life, and I continue to believe in the mission to improve the lives of others. In this section, I hope that you leave here being better able to understand the complicated landscape and role of Medicaid, particularly in maternal and child health, to identify opportunities for effective implementation of Medicaid to improve particularly maternal and infant access and well-being, since I know that's the focus for many of you and for CityMatch often, to apply lessons from past policy efforts to change Medicaid, positive and negative, and to consider the new context for and threats to Medicaid policy. I want to just start by reminding us that Medicaid is a hugely important source of coverage. It's 18.7 million women of adult age. We don't have the latest estimates yet for just women of reproductive age, but it is the majority of this number. This on the right shows you how disproportionately people of color are. So I'll just say for you, to example, the indigenous American Indian Alaska Native people are 1.3% of the U.S. population. 43% of them are represented Medicaid, or the Black population about 14%, and yet almost 39% have Medicaid coverage. People of color are disproportionately likely to be covered in Medicaid because they're more likely to have low income and because they're less likely to have jobs that offer employer-based insurance. Medicaid, as you know, covers a wide array of services across the continuum of reproductive and pregnancy health. So it is the largest single payer for family planning, many times over the size of what we have in Title X, although Title X infrastructure is very important. Family planning is a required service. It covers almost all FDA-approved contraceptives as well as testing for STI, HIV, and cervical cancer. A provider choice is assured by the law, at least. Things like infertility tests and some other things are not required and not consistently covered by states. Prenatal services, I think you all know, most of these elements are required services. Home visiting and genetic services are the exceptions here, only covered home visiting by about half of the states and genetic services by still fewer. Services around the time of birth, the birth facility, labor delivery, and care for the newborn, including care for complications such as the NICU. Coverage of midwifery and freestanding birth centers is required, and an increasing number of states are covering doula services. We'll talk more about that in a moment. And postpartum, having the postpartum visits and family planning, breastfeeding support, case management, and where states want to structure it, things like interconception care, management of those who have higher risks. The percentage of births financed by Medicaid is estimated to be 41% based on birth certificates. I believe it is closer to half of births based on the number of infants that are covered. And we have some studies that show us birth certificate data underestimate, but it's still a big number. And there are 15 states that finance 43% of more births with Medicaid. Nearly all states have adopted the Medicaid postpartum coverage extension option. You can see the exceptions on the map, where Idaho's still planning, Michigan has a limit, and Arkansas is resisting. The postpartum coverage implementation is really going on right now, and I just wanted to mention how important it is because eligibility is necessary, not sufficient. Enrollment matters, access to care, the appropriateness of the care, both medically and culturally, and whether it's respectful care and meets the level of risks and need the woman has, and thinking beyond the initial postpartum visit to what do we really want to have happen for that woman in that year. If every state extends it, it will be 2 million mother-baby pairs. It's about 2 million babies end up in Medicaid. I mentioned that enrollment processes matter. We know that federal law has long guaranteed a year of continuous enrollment for babies. You can see from one of my studies on the left, roughly 500,000 infants are not rolled for at least 90 days. This is not related to the birth trend. We've done that analysis. It's related to variation in administrative practices. I have great concerns that the postpartum coverage extensions are relying on those same continuous coverage provisions that states are using for babies. So where it wasn't working for babies, it's probably not going to work for the postpartum women to get their care continuously. Starting January of last year, all states are required to give 12 months of continuous coverage for all children. We know that's not happening everywhere, although we've made progress. So these things depend on effective state eligibility and enrollment processes. We know we also had what was called the unwinding, with many people removed from Medicaid eligibility who really were actually eligible. So knowing about this in your state is important. I just wanted to highlight one opportunity, thinking about expanded access to doula care. I did some writing about this and worked with Hoda Shaki on a publication last fall. We all know there are a number of other sort of Health Connect One and the National Academy for State Health Policy and others who've been writing about this. You can see on the map, the green states are actively reimbursing. The yellow states are implementation in progress. The bright blue is action has been basically proposed but not taken, and no actions in the states with the light gray. So we really have a lot of strategies for making this work. And I think if you use the references here, you will find out more about that. I want to talk about the context for policy. Hold on, I'm going to get a sip of water. I'm not going to read this right now, but many of you, because you're friends of City Match, have seen this Grace Abbott quote. Grace Abbott, native of Nebraska. And really to think about what Grace Abbott said she was doing, because the responsibility is hers. She took a very firm hold on the handles of a baby carriage and wheeled it into the traffic. That was the great traffic jam of what was happening on Capitol Hill. And that's really where we are today. We are going to have to put our hands on the handles of the baby carriage and get into this traffic. I'm going to talk to you for a few minutes about my some of the work from my Politics of MCH Policy long-term research project. My retrospective goes back to 1977 and through the last year. It uses the Kingdon theoretical framework. John Kingdon's a political scientist who kind of put out a model that says how and why do issues get on the governmental agenda, specifically the congressional agenda. And he talks about the problem stream, where the problems are defined and elevated. Does Congress see this as a problem? Is it a problem that has a policy solution? The policy stream, where policy solutions and many alternatives are formulated by think tanks and advocates and others. And the political stream, which is the larger sociopolitical environment. What's the climate? What's the national mood? How do elections affect what happens in that political stream? So I think most of you know that there were 6 successive expansions of Medicaid between 1984 and 1990 that added millions of children and pregnant women to the Medicaid program. We're still building out on that. We finally then, by the 1990 coverage, phased in all poor children. I would just say at the same time, poor elderly coverage under Medicaid to supplement Medicare came in, a variety of other things. But this was done on a bipartisan basis. It was an incremental series of problem definition and policy proposals, but a lot of it related to infant mortality. There was a cohesive policy community in Washington, D.C., where people really agreed this was a priority. And there was consensus about the value of prenatal and infant care and about coverage. There was a Democratic control of Congress and a national mood sympathetic to issues. Medicaid began to be delinked and seen as distinct from welfare cash assistance at this point. We had that incremental expansion. The EPSDT benefits guarantee was reaffirmed and clarified. And states' varied response yield disparate results. How states have implemented these policies really mattered. I'm going to take a great leap forward to 1994 to 95. This was not the first time that a Medicaid block grant had been proposed, but this was a major turning point for this particular policy proposal. President Reagan had proposed it, but it did not go far. In this case, there really was a big pushback by Republican governors, and the Medicaid costs and having too many mandates to cover too many people were defined as a problem. There was very intense partisan debate. And President Clinton had really as a governor, a really important view on states making their own decision. There was a fragmentation of our policy community. Some thought that Medicaid expansions were most important, and others thought that was not the most important. But ultimately, child advocates joined with poverty advocates, senior advocates, veterans advocates, others, to preserve the entitlement. This is the time that you might remember as the so-called Gingrich Revolution with the takeover in 1994. There's a parallel to today, although we had then President Clinton. There's something called a policy legacy, and that really says to us what kind of hangs on after this policy discussion went on. And one was that the block grant approach became just a year or two later applied to the CHIP program and other future block grant proposals. It was not enacted. Congress did pass it, but then at the last minute, President Clinton vetoed it. And it really challenged a lot of our thinking about protecting coverage for pregnant women and children in particular. In the Affordable Care Act period of 2010 to 2016, of course, this was a culmination of 50 years of fighting about really extending health coverage. Um, that children's advocates didn't need a big push because so many kids had been covered already. This really became a priority for President Obama. And as you know, it passed, but with continued pressure to repeal it. The Supreme Court nullified the Medicaid mandate for all states. So initially, only half of states expanded Medicaid, but the whole bill was adopted, but still leaving a lot of political controversy. In the Trump first administration, in the context of health policy, there were threats that were then and now. There was Republican control of Congress. There were and will be further efforts to cut back and limit Medicaid. There was a Republican congressional desire to work hand in glove with the president, and an entitlement backlash that continues to be part of the political stream. In 2017, the Medicaid block grant proposals returned, and they were put into that package as a part of the Affordable Care Act repeal legislation. The Affordable Care Act repeal legislation failed, although many people would say in part because they tried to tackle Medicaid and the ACA repeal at the same time. And many people, most of political policy observers, would say that the disability rights activists really helped to defeat the Affordable Care Act, repeal legislation, and that Medicaid block grant. I'm telling you all of this just in part to tell you this is my fourth round with looking at Medicaid block grant and cap proposals in 94, excuse me, in 84 and 94 and 2017 and now. So fast forwarding to today, we have a new Congress, a new administration, and a renewed bullseye target on Medicaid. Joan Alker and her colleagues at the Georgetown University Center for Children and Families are working intensively on this. I am doing some consulting work with them as well as with George Washington University on this Medicaid defense topic. But really quoted today, an existential fight about Medicaid future likely lies ahead. I am saying about this that the Medicaid entitlement is on the block for this year. And I'm going to show you why the Medicaid entitlement is at risk. The Republican congressional leaders are calling for Medicaid cuts. This is just a little bit ripped from the headlines. Overhauling Medicaid, eyeing Medicaid reform, facing big cuts in work requirements. This is in some piece of the news almost every day now. The proposals that are on the table now include, on the left, really thinking about whether it's a per capita cap or a Medicaid block grant. In either case, it's a radical restructuring of Medicaid financing. It's a change in the federal-state partnership. States would receive a fixed amount of federal Medicaid funds regardless of their actual costs. That's the risk. What are the political arguments in support of that? Oh, states will say they want flexibility. Well, they want flexibility to take things away. The feds would be very delighted to have Medicaid spending capped, either by a block grant or a per capita cap mechanism. In either case, they would say this is the upper limit for all of the money we intend to spend on Medicaid, rather than being an open-ended entitlement. And on the right, I've identified some of the other structural threats. So a lot of talk about eliminating the 90% federal matching rate for the Affordable Care Act Medicaid expansion. That's still in effect. That is encouraging many states to keep covering the population in the Affordable Care Act Medicaid expansion group. And there are even some states where there's a trigger so that if the 90% rate is reduced, their expanded coverage would end. There is a lot of focus on adding work requirements. For who and how far is unclear, whether through federal action or state action is unclear, but this is clearly another threat. The elimination or restriction of the use of provider taxes, which are used to finance Medicaid to a large extent in many states, and increasing rules and red tape that would slow enrollment and eligibility processes. So what are the arguments that people are making about capping Medicaid? One is that Medicaid growth is out of control. Here are the data. We're believers in data, right? So here are the data. Medicaid growth is not out of control. And you can see that lower line. Yes, Medicaid is growing quite intentionally as we've made state and federal decisions to cover additional people, but this clearly is not out of control spending, particularly in comparison to Medicare and private insurance. Another discussion is about that Medicaid expansion. What some conservatives are arguing is that it's not fair to kids that these adults get an enhanced match under the Affordable Care Act expansion. They're using a fairness argument for this, pitting kids against adults. Just as a reminder, 41 states, including DC, have adopted and implemented the Medicaid expansion. You can see there which states have and which states have not. A reminder that the Affordable Care Act expansion improved coverage for maternal and child health populations. So on the left, women of childbearing age comparing the uninsured rate in the lavender, if you will, the expansion states, and in the dark blue, the non-expansion states. Likewise, for children, a substantial difference between the states that have adopted the Affordable Care Act and those that have not. Clearly, for the women of childbearing age, they were much more likely to be uninsured and to be out of Medicaid than were low-income children. And you might ask yourself, well, why did these kids come in? There were some children who were additionally covered when states expanded, but mostly this is about the whole family knowing that it could get Medicaid for one or more members, and that when the parents get covered, the children come in as well. They are proposing to reduce or cap the federal matching. This is the federal matching rate overall. You can see in the turquoise, those that are hovering around 50, 51%. Then looking at that deeper blue, those that are sort of going from 53 to 60, then above 60 and above 67.5 to 76.9. The darkest blue is the highest level of federal matching, and that is based on the poverty levels in those states. This is a Nebraska example that was prepared by the Georgetown Center for Children and Families. So the FMAP, that's the regular federal matching for a service to a traditional population. This would typically be what we were using for children, poor children in Medicaid, or a parent, single mom living below poverty. So the state gets $57.50 from the feds for every dollar that they spend. With the expansion match rate under the Affordable Care Act, they're getting 90 to 10. And the EFMAP applying to CHIP, it's called enhanced. I think they started calling it E just to keep it distinct from the expansion. Again, they're getting 70 cents, to just under 30. And these are dollars, but it works with cents. If this were suppressed, so if, for example, the expansion rate was brought down to 57.52 and the CHIP rate was brought down to 57.52, it would mean millions of dollars of lost funding for Nebraska and any other state. The Center for Budget and Policy Priorities has done a preliminary analysis. While we don't know exactly what a per capita cap proposal would look like in Congress, we do know ones that have been proposed before. This analysis uses the Medical Consumer Price Index, the CPI-M, and they've done it augmented for the disability and elderly population, but basically saying um, the top number of states did not exceed their cap in this 4-year period if it were capped, and then only increased by medical consumer price index. And then you can see for expansion adults, for other adults, for children, for people with disabilities, and for the elderly, how many states would exceed their cap. In other words, they would exceed the amount of money that the federal government was willing to give them for care for these populations. So the bottom line is that any major changes to the Medicaid financing structure would have significant impact. It's half of all children. It's nearly half of all pregnant mothers. It's all poor seniors. It's many seniors in their homes and many seniors in nursing homes. It's most people with severe disabilities in facilities and in home and community-based services, and many other low-income people, particularly working poor adults and who rely on the program coverage. It would jeopardize eligibility and coverage levels. It would likely remove the guarantee of benefits, such as guaranteed maternity care, family planning, or EPSDT for kids. It would severely impact children with special health care needs and people with disabilities. It would add pressure on other maternal and child health programs in your state budgets. And it would put families and states at risk during an economic downturn. The reason these things are true is that if there isn't enough money and states have flexibility, they're sort of given X amount of money and they have the flexibility to decide how that money is going to stretch. They will have flexibility to change things like eligibility, benefits, and populations. So state choices to offset the capped federal funding to increase state spending, which is not likely in every state, certainly not a foregone conclusion, although they may have to do some of that. They may close or cap enrollment. They may impose more red tape to suppress enrollment and coverage. This might include even the work requirements here. They might reduce income eligibility levels. Say they've gone to 133% of poverty for the income uh, of those who are coming under the Affordable Care Act expansions. They may revert back to 40 or 50% of the federal poverty level if the ACA expansion money is gone. They would have likely the flexibility to cut or limit benefits in ways that they choose without consistent guarantees across the country. They would likely get more opportunity to increase enrollee costs, such as copays and premiums, and they would have the flexibility to lower reimbursement rates for providers. They might do any one of these, they might do all of these, but clearly these are the main choices that they will have. So what are we looking of this slide, but I wanted you to have this so that when you take away the slides in the recording, you actually have this detailed language. So what we know, ripped from the headlines, that the Republicans in Congress intend to work with the Trump administration. They want to use the so-called budget reconciliation process to address their priorities. They want to use it, for example, to extend the tax and make permanent the Trump tax cuts. They want to use it to change policy on entitlements. Before Congress can consider budget reconciliation legislation, it has to first develop and pass a budget resolution, which sets targets for spending. They are working on that now. If Medicaid is in there as one of the targets, it is likely it will end up in budget reconciliation. So people are already starting to work against having Medicaid be in the budget, Medicaid cuts or caps be in the budget resolution. The budget reconciliation bills, why do it this way? They enable both the House and the Senate to pass something that has, because it has direct impact on the federal budget. The things that can be in there have to do with spending and revenues and the federal debt limit. This is not program reauthorization. This is not appropriations typically. This is other kinds of budgetary work. If they do it through budget reconciliation, they can do it with a simple majority of votes. This avoids the 60 vote threshold required in the Senate. It gets them out of the risk of the filibuster. So it is an opportunity to do things with a lower threshold for number of votes, among other things. But they do have to balance it. If they're going to do spending, such as in the tax cuts, then they have to have revenues, such as Medicaid savings or savings on SNAP, the food stamp program. There's a lot of questions about whether they would put the federal debt limit into this first round. They can do more than one. They have aimed at Medicaid as a part of budget reconciliation. The discussion in Washington is that this could be passed as early as March 2025, which is why I asked City Match to let me talk to you about this. And I would just say we really need people to understand the implications of this for their programs, for the maternal and child health populations. We need you to talk to your congressional delegation and tell them why Medicaid matters. We need you to talk to your governor's offices and your state legislators, who can in turn carry a message to Congress. It is going to take all hands on deck to do this. I will say to you, this is my fourth round of working against a Medicaid block grant or cap. This is the first time I have real questions about whether we can hold on to the entitlement. If we don't have advocacy from all over the country and change the minds of a sufficient number of members of Congress, we will lose the Medicaid entitlement as we know it. As I said, I'm working in particular with the Georgetown Center for Children and Families on this. They are taking an all-hands-deck approach to doing this. They're having multiple blogs about this on a weekly basis almost. I've given you the link for the blog, the link for their guide to Medicaid 2025. So for example, they have a nice blog telling you really in more detail about how budget reconciliation works, or giving you the more words to describe these proposals, or more data to talk about who would be impacted by these kinds of change. So I'm really delighted to talk to you. I'll just say to you, my slides include a general set of select references. These are my favorite references on maternal and infant health and Medicaid. It's 2 pages worth. Use them as you choose. If you, not just for this purpose, but really if you want to have an opportunity just to use them in grant proposals or wherever else you might want to use those. So I'm going to stop there. We do have time for discussion and we have time for questions. And I'm assuming Hallie's going to moderate questions. And please do the evaluation. I care, City Match cares. We want to know what you think. You could say, oh my God, she has so much information, it went too fast. Or you could say, oh, that was the best webinar I ever attended. Whatever, just tell us.
Yes, there we have a question in the chat from Mary. Can you provide the slides? Yes, I can send out the slides. Kate provided me a PDF, and I will send those out to those who registered. But if you have questions for Kay, please come off mute and ask them freely, or feel free to add them to the chat.
And feel free to turn on your camera because I'd be delighted to see you. And I see Tanisha and Nancy from the Georgetown Center for Children and Families. And if either one of you wants to jump in, please do. Erin Jones, hi. Erin and I talked about this, was that last month? I don't know. It was recently. Erin, do you want to jump in here and add what you're hearing from the March of Dimes?
Well, I was so happy to hear you talk about what we got to do across the country, because that's what we're working on. We really have to mobilize. We've got to get this message out so that people truly understand what it is they need to say to their legislator, so they understand the impact of changing Medicaid and what that means, especially for benefits. That's from our perspective, from the March of Dimes perspective, we're really concerned about the benefit package, especially for pregnant women.
Absolutely.
So we're right there with you.
Thank you, Erin. Erin's doing great advocacy there at the March of Dimes. I love to see it. Nora?
Hi, my name is Nora Kropp. I'm a community-based midwife in Illinois. Thank you so much for the presentation. My question is, what can people in a state like Illinois do where often we get calls to write our legislators and you know, generally it's very supportive, and our state has many policies in place already to protect these benefits. What can we do opposed from writing our already supportive legislators? Thanks.
Well, I think it's a really good question, Nora, and I live in Vermont. So I have Senator Sanders and Senator Welch and Representative Rebecca Balint, who clearly are supportive of most of the positions I hold on health issues. I do think that getting them to back up, getting people from your state to back up the positions and help arm your members of Congress. Not all of their offices are really experts on Medicaid. Opportunities for them to make comments in committee, opportunity for them to put things in the congressional record, opportunities for them to talk behind closed doors to members where they think things are malleable, where they see we want them to be armed. So I see a bunch of questions, and maybe Erin has another add-in on this. I see a bunch of questions about talking points. Several organizations are working on fact sheets. I really think for our MCH purposes, again, the Georgetown Center putting things up and making available information. There will be some state-by-state fact sheets coming. I know I'm working on some, and also by population. So if you're the person who cares about Part C IDEA early intervention, you got to tell them that the majority of kids who are getting Part C services are having money, some of their services paid for by Medicaid in most states. Not true in Ohio and a few others, but in most of your states. If you're the person who really cares about maternity care and your state is 40, 50, 60, 70% in Louisiana, you really need to say to your governor's office, to your state legislators, and to your congressional delegation, this is how this impacts us. We're going to have more examples of that coming. I see, Alexa, I hope I pronounced your name right. You don't have many supportive legislators. All the more reason to give them basic facts. They are being fed basic bad information every day from conservative think tanks. And they need to have you say, this is what matters in your district. This is how many women you're supporting. This is how many kids and families this supports. This is how we keep the doors open on our special education programs, on our disability programs, whatever angles you think work for that legislator, because they're getting fed information like, oh, we should repeal that Affordable Care Act 90% matching rate because it's not fair to kids. We need to tell them that's not really been bothering us. Kids covered. We want to keep kids covered. Kids services are getting paid for. We don't want them to repeal that. That it affects the overall economic health. If you have hospitals that you work with, clearly they are organizing. I know the children's hospitals are organizing and the American Hospital Association organizing. They can be allies. Maybe you have a little Medicaid defense group that somehow, leaders from the local health department and other local programs actually just agree to keep up with stuff. You have a little group where you share information as it comes along. We are trying to keep up and catch up. Hannah says, per capita caps. I don't think we have an idea what the rate would actually be. Again, if my friends from the Georgetown Center have something more specific, we are looking at past proposals, and whatever the cap rate is, it's a cap, right? If they say, and it's unequal. I didn't go into that level of detail, but we do have some good maps which show you, if you're already if you're paying $1,000 per head, right, per person, where your cap is going to be set is different than some place that's paying $2,000 per person. You will be capped at that lower performance, at that lower rate. We have every reason to believe it will be based on your current per capita spending. And it really varies widely. That $1,000 to person to $2,000 per person is not an exaggeration. I have examples for that. So particularly if you're in the Southeast or the West, you probably already have a low per capita spending, and you would likely get locked into a lower per capita spending under a per capita cap. They might make it so that those are adjustable for adults and children. There were proposals like that before, but what we know is the cap is the cap. So in some ways, it's a theoretical thing, right? So the state's going to get, let's say they're going to get $1,000 per person, period. If somebody has a need for specialty care and that person has, you know, $1,800 in expenditures, that money's not going to be available someplace else. They will run out of money. That's the point. They will run out of money because it's capped. It's not really likely to work as, oh, you only have $1,000 worth of benefits this year. It's the federal government's way of calculating how much money they will give you and where it will end, where the ceiling is. Thank you. Nancy just put the latest blog about the per capita cap proposals. An excellent one. Other questions? I think making the case in 2017, people with disabilities put their bodies in the hallway of Congress and said, you can't do this to us. We can't live if we don't have this coverage. And we need to tell them that moms and babies won't live if they don't have this coverage, that children with special healthcare needs and disabilities won't live if they don't have this coverage, that these are really life and death matters for our maternal and child health populations, and that we absolutely cannot afford to scale that back. We can't afford to pay our hospitals less or our providers less, or tell people that they, you know, they just can't get physical therapy for their child this month. Glendine says, I'd not really thought about the potential impact of those needing nursing home care. Yes, absolutely. AARP and other senior organizations are definitely on this. Glendine, can you come on live and tell me what you're thinking about work requirements and subsidies? I want to be sure.
Sure.
Okay, thanks.
Like UK, I've been around for a while, so I've been through this several times. And one of the outcomes of having work requirements in the past was that people, the jobs that they were able to successfully get were the lowest paying jobs, and they couldn't afford childcare. We had children dying in cars because the parent would bring the child, leave them in the car during the work hours, and of course, heat and so forth. Um, it was perilous to wait too many
Yes.
children. Even one is too many. So I'm curious whether there are conversations going on about, looking at this in the broad picture, like not just looking at, okay, we're going to have work requirements, but looking at what that means and what is needed in order for those to be implemented in a safe way.
Yes, absolutely. That's very well said. And clearly what we would like Congress and others working on these policies to understand is that a substantial proportion of people, adults in Medicaid, have disabilities that don't necessarily enable them to work up to a standard expectation. We also need them to understand the point that you're making, and I think it's up to us as maternal and child health advocates to make the point that that working, how soon you go back to work after you have the baby matters. Work hours where you can't meet your childcare expectations matters. And so it's not only an issue for people with disabilities, but particularly for mothers with babies, and thinking about how they keep them safe and how they themselves stay alive and keep that baby alive. Really, I would say to you that Thanks to Jennifer House of many of you have heard me tell this story. I apologize, but it was such a striking story to me that Jennifer House, then president of the March of Dimes, and I, as the national policy director for the March of Dimes, we went to meet with Newt Gingrich. Just Jennifer and I. We didn't even have a staff person in the room. He sat and listened to us for an hour. And we persuaded Newt Gingrich that protecting pregnant women and infant coverage up to 100% of the federal poverty level was an essential element in his block grant proposal. And he did it, and he protected it all the way to the veto. I would have been the last person to tell you that I could persuade Newt Gingrich to protect pregnant women and infants in poverty in the Medicaid block grant battle. But I did. And so I do not want you to underestimate the power of making a case with data, with passion, with the image of real people behind it. We helped him understand how there were a lot of working families, that Medicaid wasn't a welfare program, that there weren't a bunch of cheats in the program. We helped him understand that this was a program helping pregnant women and babies keep their health, and he actually heard it and protected it. I really, the day that I was told we were going to go meet with Newt Gingrich, I almost quit my job because I was going to go on strike, not wanting to meet with Newt Gingrich. Thank heavens I didn't. Don't underestimate your power. You have data, you have local stories, you have ways to get information from your hospital or your OBGYN providers or your Medicaid agency. Most likely your Medicaid agency doesn't want this to happen either. Your PRAMS data have Medicaid information in them. Use what you have to make the best case that you can, and we just need it to happen all over the country. Chris, do you want to talk? Please.
Sure. Hi, my name is Chris from Missouri. I'm in St. Louis. I'm a community health worker manager over the perinatal team, and I just had some encouraging words. I was encouraged by your story because, of course, I'm in St. Louis and it's very red state. Seems like I would be in a losing battle over here, but hearing you talk about the examples that you gave, the stories is really, we live in an area in St. Louis where there's most of our patients are here on Medicaid, and it's it would they need some advocacy over here. So, how did you put that together as far as like um, listing examples of mothers and babies and situations and stuff,
Yep.
or like
Yep,
how do you
I did.
speak to your
I,
political
I,
leaders?
I did my best city match work, right? I used my data, right? I could show him how many, he was all about the working thing. I was like, well, here's how many of these people are in families where one or both parents works. So that was his thing I needed to overcome, right? And then to show him, you know, that we really had an opportunity to improve health, like in aggregate, you know, and we got coverage and we got more prenatal care, and I showed him that. And then bringing some specific Georgia cases to him. Here's what's
Mhm.
happening to people you represent in your district. And March of Dimes was able to do that through the Georgia chapter at that time. So, you know, use your data, use your storytelling narratives, and, you know, make the case that they need to
Right.
hear.
Do you suggest
Question.
that I get with like different organizations? Like, do you suggest some good organizations that are good with policy that can, help with talking points, or that could go with me to, to talk to these Congress people?
Yes, I think so. I don't know what Aaron has to say about that, but certainly with the Georgetown information and fact sheets and how we're structuring, what I'm working on with George Washington University, we're making fact sheets for community health centers
Hmm.
because 60% of their patients minimum really on average are going to be, and that's low because so many of them are undocumented and uninsured, right?
Hmm.
But they've got a and if they lose Medicaid, if their patients lose Medicaid coverage, it's really hard to make that up. So yes, I think these fact sheets and things will be coming, and I can help Callie get out some more updated and specific information. But start with the links at the end of my slides and what Nancy put in the chat.
All right.
Eileen,
Thank you.
thank you. Eileen?
Hi there. I'm Eileen Fitzpatrick. I'm from Baby Friendly USA. We accredit maternity care hospitals for best practices in the Baby Friendly Hospital Initiative. And we have seen a huge number of OB closures just in our program, 26 in the last 3 years, which is a huge number. So is there a way to calculate the impact on increasing maternity care deserts with cuts in Medicaid? Is that data available, or is it possible to do that? I know March of Dimes has their maternity care deserts report, but is there a specific data on that?
I'm going to ask Erin, are you thinking about impact?
We are,
Yes.
and Ashley Stoneburner, who is my counterpart, is on this call, and she's actually doing what you just asked. So I don't know if she's still able to talk, but she's looking at these exact issues. I don't know if Ashley's still out there.
Yeah, I'm here. Thanks, Erin. I was like walking on the treadmill, so I'm out of breath. Yeah, we have another report coming out in 2026. The issue is the data lag. So if these policies go into place, it will take a couple years to see the impacts. But we're looking at it for sure.
Okay, thank you so much.
Very good. Again, that other angle, Eileen, you're bringing up another angle. How does this impact our hospitals and our maternity deserts in particular? It's an issue that a lot of members of Congress have been concerned about and can bring forward. And if we're arming them with data, I think it matters. I want to go back to, I don't want to ignore the question about undocumented people. I think the cross-section or having this, having undocumented people in the dual crosshairs here, crosshairs and with the threat of deportation and crosshairs with the threat of being the first ones out of Medicaid in a state where they would be looking to cut populations. I think they are really at double risk, double jeopardy there. Again, think of this as sort of, if the state's only going to get X amount of money, whether it's based on a per capita cap or other calculation of a block granted money, they're going to get X amount of money. What are they going to have to do? Where are they going to go to cut first? You know, they're going to look at that ACA expansion population, which is a target. They're going to look at undocumented people. They're going to look at people who are not working. They're going to put more severe restrictions on people with disabilities than they already do under the waivers for home and community-based services. They're going to try to ratchet down prices on hospitals and nursing homes. Those are the standard targets, and I can't even begin to contemplate the other targets that they have. It might be kids and, you know, kids over, it might be youth, right? So where some states are going to 21, they might ratchet back to 18, or revoking their postpartum expansion. It's an option. First in, first out. Maybe the last thing they did that was positive, that they may want to just pull that out, that they could say, oh, well, we barely got going on that, so let's just go there first. I think the insidious part of this is the people who make the case in Congress and the conservatives who make the case in media are going to say, oh, we're cutting that ACA match rate because it's unfair to kids. They're going to say there's all this fraud and abuse and runaway growth in Medicaid. They're going to say, oh, you know, it's, you know, all these undocumented immigrants are illegally getting a Medicaid card. They're going to say that people who don't work shouldn't have public benefits. And we really got to make the case that none of those things are true.
There was one more question that I don't think has been addressed yet, but just given similar Medicaid battles before, what about this moment is unique or different?
Well, I think what's really unique and different is that there is Republican control over all three bodies. So we got out of the, I mean, Congress passed the Gingrich era block grant. And albeit I we protected pregnant women and infants, they were going to throw out children with special health care needs, baby with a bathwater. It was really going to be not pretty. But this time, but we had, in the end, we had President Clinton to veto it. In the Reagan era, Reagan had so many budget cutting priorities. This one didn't get up the list before he lost in the midterms. So part of our thinking is how do we just hold on to this through the midterm elections when maybe one of the other bodies would be turned back to Democratic control. But right now, there aren't any guardrails on this other than constituent voices counteracting the conservative arguments. And that's, as Erin said, we really need everybody to mobilize all the way across the country to get that. We don't have March of Dimes does with chapters across the country, or the Hospital Association with members across the country, or to some extent provided the American Academy of Pediatrics is very concerned about this, and so on. But we as an MCH public health community know the value of this, and with City Match representing all over the country, you really have to be part of this response. We need you. Thanks, Erin. You want to say more about that?
I think everyone's probably seeing it. Fox News didn't exist during the time. You know, they didn't have that whole group of folks that are just really targeting, I hate to say it, in some cases, misinformation to a group of people who make decisions. We're
Yes.
seeing it in the vaccine world. I do a lot of work on vaccines, and we're seeing that translate into other areas. And I think Medicaid is one of them. It's the most expensive thing on everybody's state budget. It's the shiny object that gets the most attention.
Yes.
And so I think that's what we're coupled with. I think that's the hard part.
Thanks very much, Erin. Kelly, I think we're at time.
We are. I feel like this conversation could go on for the rest of the day, as it should. And I think there are a lot more steps that I will work with Kay to get to you all for who registered, and just some conversations to be had in our own states on how we can stop this cuts from happening. But I want to take a moment to thank you, Kay, for all this information you gave us. I feel like you did motivate us and encourage us to speak to our representatives and go out and keep these things in place, what we need. Again, thank you to everyone who attended today's webinar. We will have one more coming up in February, February 4th, but thank you again for this conversation, and I don't think it ends here. So I appreciate you starting it up for us.
Thank you so much. Thanks to all of you who were here.